All right. Thank you everyone for joining. We're going to get started in a few seconds. Thank you for your patience. All right, in the interest of time, we're going to get started here. So good afternoon, everyone. Thank you again for joining today's briefing on health workforce diversity. My name is Danielle Moon. I'm the Director of Programs at and Community Engagement at APAICS, the Asian Pacific American Institute for Congressional Studies. As many of you may know, APAICS was founded alongside with CAPAC, the Congressional Asian Pacific American Caucus, in 1994, with a mission to increase the political pipeline for the API community in public service. Since its founding, we've had our Congressional Fellowship Program grow exponentially over the years. Last year, we started a new cohort of the Racial Equity Fellowship Program. And so today's briefing will be led by two of our health fellows, Faraj IR with Representative Barbara Lee and Jennifer Min with the Congressional Hispanic Caucus. I'm so proud of their accomplishments and look forward to hearing today's briefing, as I know they've worked so very hard to put together today's briefing. So without further ado, I'll hand it over to Faraj and Jennifer to get the briefing started.
Hi, how's it going, everyone? Thank you for joining us today. My name is Ruiz, and I am a 2022 APAICS Racial Equity Fellow in the Office of Congresswoman Barbara Lee. It has been an immense honor to work with her for her during these last few months. I want to thank her and her staff for all their support on an issue that is incredibly close to my heart. I would also like to extend a special thanks to APAICS, Kaiser Permanente, the Tri-Caucus, and Representative Ruiz for their support. I'm excited to moderate today's discussion featuring three highly qualified panelists on HEAA Title III workforce diversity. HEAA is a bill that ensures all Americans, regardless of their race or economic background, have access to quality healthcare. Title III helps doctors from underrepresented communities achieve the education needed to participate in our healthcare workforce. These doctors are best suited to serve the communities, which overwhelmingly suffer from a physician shortage. As you may know, America's doctor shortage is a significant health equity issue that must be addressed. We must not only diversify our workforce for greater inclusivity, but also remove barriers that prevent qualified international medical graduates from practicing medicine. IMGs are often the ones tackling a disproportionate share of America's biggest healthcare challenges. Unfortunately, because of current laws, it can take several years for them to recertify their foreign medical licenses. My own mother, Dr. Sonali Ayar, a woman of tremendous will, overcame these hurdles. An immigrant doctor from India, Dr. Ayar, at the age of 38, was required to complete an additional 6 years of medical training. Considering that she had already spent 7 years in India on her medical education, she has spent a total combined 13 years of her life on her education. That is a total 13 years of time that America cannot afford to lose. My hope is that today, he is going to be finally part of the solution. And now I will hand it over to Jennifer Min, my APAICS colleague.
Thank you, Viraj, for that introduction. My name is Jennifer Min, and I am an APAICS Racial Equity and Social Justice Fellow in the Office of the Congressional Hispanic Caucus, which is led this year by Chairman Raul Ruiz. He is a doctor and represents the Congressional 36th District of California. While our nation has made progress towards equal access to healthcare, people experience poor health outcomes due to race, religion, and socioeconomic status, in addition to education, sex, and the rural-urban divide. The COVID pandemic has only highlighted these health disparities and resulting health inequities, particularly for those in historically underserved and minority communities, including, but not limited to NHPIs in Hawaii, Latinos, African Americans, and those in rural communities. And that is why it's been such an honor to learn about these health disparities and specifically how Congress is working to address them, including through HEAA. And it's also been an honor to learn about the perspective of the Latino and Latinas nationwide, and to also better understand the linkages between our two communities. I thank Kaiser Permanente for sponsoring this fellowship, and am honored to introduce Nancy, who is the co-chair of the Kaiser Permanente Asian Pacific American Islander Association. Nancy will provide brief remarks, and I pass it off to her. Thank you.
Thank you, Jennifer. My name is Nancy, co-chair of Kaiser Permanente Asian Pacific Islander Association in Mid-Atlantic. Founded in 1945, Kaiser Permanente is one of the nation's largest nonprofit healthcare plan. A key component of our success is our ongoing commitment to integrating equity, inclusion, and diversity into our mission. Beyond providing high quality care with affordability, we are also deepening our efforts to get at the heart of inequity, addressing systematic racism, and creating an inclusive society. During the COVID, Asian Pacific Islander community has faced two dangerous challenges. One is deadly pandemic, and another is the 150% surge of hate against the Asian Pacific Islander community. Kaiser Permanente Asian Pacific Islander Association and Kaiser Permanente worked together, allocated $5.4 million to fund Asian Pacific Islander business in supporting of anti-Asian hate efforts nationwide. APAICS stands out in Mid-Atlantic region, not only for its mission, more importantly, for what it has accomplished and continues to achieve in promoting Asian Pacific American participation and representation at all levels of a political process, from community service to elected office. Today, on behalf of Kaiser Permanente Asian Pacific Islander Association, I am excited to be here, witness the achievement from two young and bright congressional fellows, Jennifer and Raj, whom Kaiser Permanente Asian Pacific Islander Association is proud to support. I want to thank Madeline, Daniel, and the rest of the APAICS team for their wonderful partnership with Kaiser Permanente Asian Pacific Islander Association, and the amazingly impactful work in promoting API community, as well as in advancing API voice in the Hill. Thank you.
Thank you, Nancy, for your remarks and for your support. And thank you, Kaiser, again to Kaiser Permanente for their support and helping Jennifer and I be on the Hill. And now we have a few remarks from Congresswoman Barbara Lee on behalf of CAPAC and CBC.
Hello, I'm Congresswoman Barbara Lee, and I proudly represent the beautiful 13th Congressional District of California. I want to express my sincere gratitude to the leaders of the Congressional Tri-Caucus, Representative Judy Chu, Representative Joyce Beatty, and Representative Raul Ruiz, for their support for this briefing and health equity issues. I would also like to thank my good friend, Representative Robin Kelly, head of the Congressional Black Caucus's Health Brain Trust, for leading and sponsoring HEAA in the 117th Congress. She is doing an amazing job. Serving as co-chair of the CAPAC Health Task Force and a member of the Congressional Black Caucus's Health Task Force, I look forward to continuing to work with the Tri-Caucus leads and Senator Mazie Hirono to sponsor the reintroduction of HEAA in the 118th Congress. As our APAICS legislative fellow, Viraj's time in my office comes to a close, I want to thank him for organizing and moderating today's briefing with APAICS fellow Jennifer Ming, who is serving with the CHC. They are phenomenal young people. Today's briefing comes at a time when we are each grappling with the challenges of COVID-19. The Health Equity and Accountability Act is a bill that ensures all Americans, regardless of their ethnicity, race, or economic background, have access to quality health care. It is a bold, comprehensive Tri-Caucus effort to improve health outcomes in communities of color. HEAA includes 10 titles that work to improve health outcomes of underrepresented communities. Specifically, HEAA Title III recognizes the need to improve the diversity and quality of our country's healthcare workforce, including addressing the physician shortage and diversity issue. Nationwide, it is estimated that we could face a deficit of up to 124,000 physicians by 2034. We need to produce doctors who best understand the health needs of their communities. Today's briefing will examine the barriers international graduates face to practice medicine in America. This is such an important topic. Because of current laws, foreign medical license recertification takes several years. Keeping such qualified doctors from practicing medicine is a tremendous waste of human capital because we know that they are more likely to practice in medical shortage areas. It's really too bad that the United States is a medical shortage area. HEAA is critical to the health of our nation because it addresses the underlying challenges that prevent underserved communities from accessing quality health care. And so with your help, I look forward to creating a system of care that is reflective of the needs of each of our communities throughout America. This is long overdue. Thank you again.
Next, we have some remarks from Representative Raul Ruiz on behalf of the CHC.
Hello, I'm Congressman Dr. Raul Ruiz. I'm an emergency medicine physician and public health expert, and I represent California's 36th Congressional District. I also serve as chair of the Congressional Hispanic Caucus. I want to thank APAICS for putting this together, and a special shout out to Jennifer Min, APAICS fellow at the CHC, for co-moderating this briefing. Before coming to Congress, I had a goal in mind. I wanted to become a doctor to serve my community and relieve the pain and suffering of the people in my medically underserved hometown of Coachella, California. After I earned my medical degree and master's in public health and public policy from Harvard University, I returned to the community to work as an emergency physician. There, I witnessed firsthand the detrimental effects of our nation's physician shortage. Nationwide, it is estimated that we need an additional 20,000 providers to end the shortage. However, we need to shift our thinking. We can not only look at the end stage of training to create more doctors, but need to build pipelines to actively recruit middle and high school students and foster their interests in the medical field. On top of building the pipeline, we need to recruit from historically underrepresented communities and partner with universities so that young aspiring doctors can enter college as pre-med, go to medical school, and then into residency to receive training to serve in those underserved areas. I know that's the two biggest predictors of where a physician will eventually go into practice. It's where they are from and where they last trained. That is why, before I came to Congress, I created a pipeline that is now housed under the University of California, Riverside Medical School called Future Physician Leaders, where I recruited aspiring doctors from underserved communities in my district. This program can serve as a model program for the rest of our nation, and we need to replicate it. We must focus not only on producing doctors, but targeting future physicians that will serve where they are needed the most. That is why I support the Tri-Caucus-led Health Equity and Accountability Act, specifically Title III, the Health Workforce Diversity, which recognizes the critical need to fund programs that promote diversity and equity throughout our country. I thank Congresswoman Robin Kelly and the Congressional Black Caucus for their leadership and hard work in reintroducing this much-needed Tri-Caucus legislation this Congress, which is co-sponsored by 15 CAC members, and for their support when CAC introduced it. And as a congressman, doctor, and chair of the Congressional Hispanic Caucus, I urge this panel to shed light on the critical need to direct funding to pipeline programs that tackle our nation's health disparities. Thank you.
Thank you for those remarks from Congressman Raul Ruiz and Congresswoman Barbara Lee. And now we're going to start off with the panelist section today. Joining us today, we have Dr. Jean Badalova, who is a senior policy analyst at the Migration Policy Institute, and she's a manager of the Migration Data Hub. We have Dr. Jose Ramon Fernandez Pena, who is the founder and executive director of the Welcome Back Initiative, an initiative devoted to helping foreign educated doctors practice medicine again in the US. And he was previously the immediate past president of the American Public Health Association. And we have Joel Burvell, who is a White House Office of Public Engagement's healthcare leader in social media roundtable, and the American Medical Association's medical student digital fellow. First, I'm going to hand it over to Joel. Joel is someone who is committed to fighting healthcare disparities in medicine through education, and he regularly shares topics about healthcare disparities and racial disparities in medicine through his TikTok and Instagram. He has over 500,000 followers on TikTok, 90,000 followers on Instagram, and he has regularly been invited to speak on healthcare issues at the U.S. Food and Drug Administration, Google, the Clinton Foundation, Network of the Library of Medicine, Verizon, among other institutions and organizations. Joel, I'm going to hand it over to you to talk about why we need HEAA Title III, and your work on diversifying the healthcare workforce.
Hi, everyone. First of all, let me say thank you so much to APAICS and the offices of Congressman Barbara Lee for allowing me to be here today to speak. As was mentioned, my name is Joel Burvell. I'm a fourth-year medical student at Washington State University, and online I use, through my social media presence on TikTok and Instagram, I share concepts about healthcare inequities. I've become better known as the medical mythbuster now for discussing these issues and how they manifest in our systems. My videos include stories that I've witnessed personally through my time in medical school, but I also highlight research that documents how health disparities manifest and take root in our medical systems. And beyond my online channels, as was mentioned, I work with the White House Office of Public Engagement on a roundtable for healthcare leaders in social media. And I also work with the World Health Organization combating misinformation on social media, especially around topics like COVID. But I've been asked here today to talk about the importance of diversity in our healthcare workforce, and how that lack of diversity in our nation's medical workforce perpetuates America's health disparities. And through a myriad of examples, that's what I really hope to do today. As a Black medical student, I know intimately how important diversity is. According to the 2019 Diversity in Medicine report from the American Association of Medical Colleges, in the United States, less than 5% of all physicians are Black, despite the Black population of the US hovering around 13%. In fact, in 2014, there were less Black men in medicine than there were in 1978. And at my own medical school, I was the first Black medical student. Representation in medicine is unfortunately low amongst many minority groups. According to the same AAMC report, only 5.8% of physicians identify as Hispanic, and less than 1% are Native American Indian or Alaska Native. And these numbers matter. Diversity in medicine matters because the workforce we serve is diverse. And quite frankly, outcomes change when patients are able to connect with someone that comes from a similar background as themselves. Take, for example, the ongoing maternal health crisis that we hear all too often about. A recent study conducted at George Mason University found that Black newborn babies were 3 times as likely to die as white newborns during delivery. The study also found that when Black babies were delivered by Black doctors, the mortality rate was cut in half especially in complicated cases. That same relationship wasn't found between white doctors and white newborn births. And why a doctor's race and background makes a difference is complicated and does need more research. But it's an example of the importance of ensuring that we have a diverse workforce that comes from all walks of life. Because when we don't, the harms, as we can see, are great. And the lack of diversity in medicine today isn't accidental. It can actually be traced throughout history to initiatives like the Flexner Report of 1910. It's why things like HEAA are needed to actually insert and remedy these problems that were made in the past. For the Flexner Report in the 1900s, the American Medical Association's Council on Medical Education commissioned Dr. Abraham Flexner with the Carnegie Foundation to look into the allegedly deplorable state of medical education. Flexner visited all North American medical schools, and he ended up writing a document that criticized the education of doctors. He proposed a new framework for the proper preparation of physicians with 2 years of academics and 2 years of clinical training. But after these Flexner reforms, many medical schools closed, including 5 of the 7 established to train Black people and all but 1 for training women. That sharply limited opportunities to enter medicine for marginalized groups until the 1960s civil rights laws made discrimination by race and sex unlawful. And that report was in part responsible for the disproportionately low number of minority physicians we see today. Imagine this. In 1920, African Americans were 2.5% of US physicians, and that number persisted until only recently when representation rose from 2.2% in 2008 to a mere 5% of today's workforce. An official apology from the national organization was issued by the AMA in 2008, and recently the AMA recognized racism as a public health threat. It's why I believe initiatives like HEAA Title III are so needed to further fund and commit to supporting institutions committed to working to workforce diversity, equity, and inclusion, and to understanding the history that's led us here and correcting that history. And there's still a ways to go. Just 6 years ago, a paper published in the Proceedings of the National Academy of Sciences took a survey of 222 white medical students and residents in order to identify false beliefs about biological differences between Black and white individuals. Surveyors were given statements to rate on a scale as definitely untrue to definitely true. The statements included comments like, Black people's skin has more collagen than white people's skin, and Black people's nerve endings are less sensitive than white people. Of those who were surveyed, about half of the individuals endorsed false beliefs about biological differences between Black patients and white patients. And those who did endorse those false beliefs were also perceived Black people as feeling less pain than white people. In a follow-up study, it was also found that those who endorsed those false beliefs were more likely to suggest inappropriate medical treatment for Black patients and undertreating pain. If it wasn't clear already, there are not biological differences based on race. Yet when we don't have a diverse workforce, these are the types of beliefs that become perpetuated throughout our system and impact the care that patients can receive. I think it's also important to understand how physicians from diverse backgrounds are already changing the medical system today and rooting out disparities that have long been ignored. Because it's an example of what can happen when we do diversify our physician workforce. In 2020, a years-long push to remove a racist bias from kidney testing finally gained ground due to increased conversations about racial disparities in medicine. In part, this push was aided by the COVID pandemic, which unearthed for many disparities that long existed in the medical system. Black physicians and medical students had for years been warning of a test that assessed kidney functioning that was racist and dangerously inaccurate. The equation, called the glomerular filtration rate, or GFR equation, considered 4 different factors: age, gender, levels of creatinine, which is a waste that kidneys filter out of the blood, and of course, race. But for some reason, the race of a patient could only be bucketed into 2 groups, Black or non-Black. For patients that were Black, the equation added a multiplier to their score. A higher GFR indicates better kidney functioning. A low GFR indicates worse kidney functioning. So what that multiplier did was it made the results of Black patients appear more normal than they might actually be. In turn, that possibly delayed treatment and access to life-saving care like kidney transplants. And studies show that Black patients already wait months longer than their white counterparts for access to kidney transplants. Now you may be asking, was there a reason why there was that multiplier? Well, it was based on a flawed assumption that dates back to the formula's creation, when medical experts presumed that Black patients have higher muscle mass on average, causing them to have higher kidney functioning. But because of the work of primarily medical students, residents, and young physicians, whose backgrounds were underrepresented in medicine, a task force was commissioned, new studies were created, and now a new equation exists without the use of race and is being implemented nationwide. But it took the outlook of different individuals who saw how their communities were being medically harmed to advocate for those changes. And changes like that need to be placed in so many places in medicine, in the lack of dermatology condition diversity of images that we see, in medical devices that read inaccurately on darker skin, in the lack of research funding allocated to support research for traditionally underserved communities, and in the discrepancies of mortality, life expectancy, and mental health. HEAA Title III is needed. It goes beyond just making patients feel comfortable. Having a diverse workforce is life-saving for patients, and the lack of diversity in medicine has for too long decimated communities of color. Thank you.
Thank you so much, Joel, for your remarks and for that informative session. Next, we will have Dr. Batlova speak. Dr. Batlova is a senior policy analyst at the Migration Policy Institute, commonly known as or referred to as MPI, and manager of the Migration Data Hub, a one-stop online resource that provides instant access to the latest facts, stats, and maps covering US and global data on immigration and immigration integration. She's also a non-resident fellow with the MPI Europe. Her areas of expertise include the impacts of migration on society and labor markets, social and economic mobility of first and second generation youth and young adults, and the policies and practices regulating immigration and the integration of highly skilled workers and foreign students in the United States as well as other countries.
All right, good afternoon, everyone. I'm Zhanna Batalova, and I'm delighted to have the opportunity to highlight key findings from the research about skill underutilization of immigrants with health and medical degrees obtained abroad that my colleague Michael Fix and I at the Migration Policy Institute have done recently. For those who don't know, MPI is a nonpartisan independent research organization that devotes time to studying the trends and impacts of migration on the receiving countries like the United States, sending countries, as well as migrants and their families. One of the long-standing topics we've been exploring is labor market and labor force trends shaped by forces like demographic changes, automation, globalization, and more recently, the COVID pandemic. We call these mega forces. It is also part of the Institute's wide thinking on the role and contributions of immigrants across all skills levels in national, state, and local economies, including in the field of healthcare, that are part of our Global Talent and Skills Initiative. The pandemic presented a unique opportunity for us to focus on immigrants in the healthcare field and help reignite attention to those who are underemployed. Early in the pandemic, we estimated that more than 270,000 immigrants, healthcare professionals with college level, so bachelor degree or higher degrees in health and medical sciences and fields, were either not working or working in low-skilled jobs. So essentially, they have been sitting on the sidelines during the nation's one of the worst public health emergencies. So, but on the one hand, immigrants are already an integral part of the U.S. healthcare system. 29% of physicians and 16% of nurses are immigrants. And they work in cities and rural areas, providing essential services, especially to underserved populations. For instance, they account for 1 in 5 doctors in rural America. On the other hand, as I mentioned, we estimated that more than 270,000 immigrants with health and medical college degrees were underemployed. And that underemployment, even at the time of high demand that we've all experienced, exemplifies a phenomenon that we refer to as brain waste. In terms of the characteristics, we found that out of the underemployed, internationally trained healthcare professionals who are immigrants, about 60% obtain their degrees abroad. Majority of them are women. Most of them are nurses. Importantly, majority have legal status. They are either naturalized citizens or green card holders, but a quarter of them are unauthorized, including DACA and DACA holders and holders of temporary protected status. They come from a wide range of countries, with some countries like the Philippines, India, Mexico, China, and others. And importantly, they bring valuable cultural and linguistic competencies. We found that about more than 2/3 are fully proficient in English. And on top of that, they also speak a variety of languages, such as Spanish, Chinese, Korean, Tagalog, Arabic. And these are important languages to know, because a large proportion of immigrant, but also even non-immigrant communities are limited English proficient, and these are the top languages that that community speaks. The legislation we're talking about is an important piece even during the normal times. We should really not waste the talent of immigrant and US-born trained doctors and nurses. But there is an additional urgency to have a legislation like that. The United States is experiencing several important long-term demographic shifts that have direct implications on healthcare system. On the one hand, we have the slowdown of the US total population growth. On the same time, the number of people 65 and older has grown significantly. It is not only the population overall that is aging, the healthcare labor force is aging as well. We estimate that about 20% of physicians and nurses who are currently employed in the US are within 10 years of retirement age. And even before the pandemic, the projections indicated that in the United States and in most states across the nation, there was a shortage of physicians and registered nurses. At the same time, in the nation and in many communities across the country, racial and ethnic diversity increased. Racial and ethnic minorities in the United States already account for 43% of the total US population, up from 34% in 2010. As Joe mentioned in his presentation, Latino and Black and other racial minorities tend to be underrepresented among healthcare professionals, which undermines the quality of healthcare provided to an increasingly diverse population, again, as Joe presented so well, given concrete examples from research. And so these trends clearly indicate that we need to have all hands on deck to provide high quality healthcare services, and the Health Equity and Accountability Act is a key policy tool and change that would help diversify healthcare workforce and address the worsening healthcare provider shortages, and immigrants could be an essential pool of workers helping us to achieve the national goals. Thank you.
Thank you, Dr. Badalova, for your remarks. Finally, I want to introduce Dr. Fernandez-Pena, Dr. Jose Ramon Fernandez-Pena, who is the founder and executive director of the Welcome Back Initiative. Among his many roles, he was previously the immediate past president of the American Public Health Association and the former professor emeritus at San Diego State University. His organization, the Welcome Back Initiative, has served more than 17,000 people from 168 countries and has assisted thousands and thousands of people in joining the US healthcare workforce. He was also he also previously worked on HEAA, providing much needed expertise during past Congress sessions. Dr. Fernandez-Pena, I hand it over to you.
Thank you very much. Can you hear me? Yes. Thank you for the opportunity to speak with you today. This is indeed a very near and dear topic to my own heart as a foreign medical graduate myself. And just one minor correction, I was at San Francisco State University, not San Diego State. So the Welcome Back Initiative was started in 2001, 21 years ago, with the simple intent of connecting community assets with community needs. In other words, it was clear, very clear, has been very clear for many years that the lack of diversity in the health workforce is compounding the nation's racial and ethnic disparities in health outcomes. I mean, going back to 2003, the Institute of Medicine report on equal treatment began to identify these issues, and then the Sullivan Commission, a year later, was appointed to look deeply into this and propose suggestions to how to remedy this lack of diversity in the health workforce. And as the congressman stated a couple of minutes ago, this is not a one answer, this is a multi-pronged answer for a number of reasons, clearly creating pathway, stimulating high school kids to get into this kind of lines of work. All these are extremely important and will hopefully provide the health workforce that we'll be needing over the next few years. My work has been on the other end of the pipeline, working with individuals who have already been trained and are residing in the United States for a number of different reasons. They came, left their countries of origin, their countries of training, and are now living among us. As my colleague, Dr. Batalova, pointed out, 270,000 more or less of them are around, and the vast majority of them are not using their skills and talents to provide the health services needed in so many communities. The Welcome Back Initiative has actually served over 22,000 people from 168 countries, primarily nurses, doctors, and many other health professionals. I understand that the topic today is about physicians, but I want to make very clear the fact that physicians are one element of the health workforce. If we look at the demographics and the aging population, and if we look at how the different conditions are becoming more and more prevalent in the community, such as diabetes, obesity, heart disease, many of these in elder populations are not necessarily so directly treated by physicians, but oftentimes it's social workers, many times health educators, it's oftentimes nutritionists, the individuals that are directly involved in the care of these populations. So I like to think, when I speak about health workforce, of a very broad set of professionals. For example, we know that it's already been said, by 2025, we expect about 130,000 physicians will be needed that we don't have right now, and that we're clear that are not going to be able to educate with the existing facilities and levels of training. But also, we estimate right today that there's a shortage of 250,000 public health professionals. And this was terribly and importantly evident during the recent pandemic, and our inability to provide education and services that were culturally and linguistically appropriate to the populations that needed the most that information. So we need to think about those pieces in the angle of prevention and not in the angle of treatment exclusively. The Welcome Back Initiative has served all these individuals, and as Dr. Batalova pointed out, 64% of them are not working in the health sector, 71% are women. For 60% of them are between 30 and 49 years of age, the most productive years of adults. 46% of them have been in the US fewer than 3 years, which is an important consideration when we think working with them and facilitating their integration into the health workforce is a lot easier than working with individuals like myself that has been away from practice for 30 years. 36% of them have at least one dependent. So these characteristics help us understand what are some of the challenges they encounter as they're trying to re-enter the health workforce. So if they have dependents, and the majority of them are women, traditional gender roles spread across the universe. So I've heard women say many times their biggest challenge they face is their condition as a woman, because they may be the doctor in the family, but they are the mother, the grandmother, the spouse, the one that cares, feeds, and protects the rest of the family. Not that I defend that, but it's a cultural norm that exists around the world. So the challenges of time and money and the ability to find time to dedicate to study, to prepare for exams against the responsibilities they have and the need of an income to support the family, because not only they have dependents in the US, but the vast majority have dependents in the countries of origin or the countries of trainment. And oftentimes they are the supporter of the family abroad. Just to paint a much clearer picture than I think it's already been painted, in the US, 66% of the population is white. 73% of the physicians in the US are white. 13% of the population is African American. 5% of the population of physicians is African American. Latinos represent 18% of the population in the US and 4% of the physicians. And Asian, and I don't like to use the construct Asian respectfully because it encompasses 30, 40 different ethnicities, languages, cultures. So if you allow me to say Asian, and I tell you that the Asian populations represent 5% of the US population, they represent 18% of the doctors. But if we were able to break down that construct Asian, we would see that there's maybe 1% who are Vietnamese, 2% that are Cambodian, and maybe different percentages for each one of the groups. So that's a very, that data really cloaks the problem a little bit. So the issues that we encounter with helping these individuals return to the health workforce are various. I'd like to classify some of them as intrinsic and some of them as extrinsic to them. Intrinsically, the lack of command of the English language is the first issue. Many of them, not all, many of them encounter. The lack of familiarity with the US health system is another big issue because in most countries, as I always say, we either have a doctor or you don't, or a nurse or you don't. And in this country, you have the nurse, the nurse practitioner, the nurse midwife, the nurse anesthetist, the RN, the ADN, the CNA, etc. So not understanding what are the possible career options for you becomes a challenge for individuals trying to rethink their lives. I already spoke about the time and money. The loss of professional identity, and maybe Viraj, you can speak to this, is a severe impact on a person's ability to reinvent themselves or to pick up where they left and start from zero again. One of the biggest challenges, I think, is that when we test foreign trained physicians in the US to grant them access to our residency training program, we're using the test that we use to assess the qualifications of recently graduate medical students. We're not assessing the competencies of an individual that has been 10 years in practice. So we're looking at the wrong end of the donkey, if you ask me. If we were able to assess their competency, we would be looking at realistically at what a person can do, not whether a person remembers the anatomy of the knee, which is important, very important for some professions, but not for somebody that has been a neurosurgeon for 15 years. The licensing processes and the bureaucracies here and abroad and the conflicting interests of third parties are also an important challenge that our foreign trained health professionals encounter. As I said, we may not be necessarily looking at the best way to assess their competencies. The bureaucracies to obtain a transcript out of a country may be complicated. I am from Mexico. I know how difficult it is to get a transcript out of Mexico if you're not there, not to mention if your country is in war, or if your country suffered a natural disaster, or if you had to flee for political reasons or religious reasons or whatever other form of discrimination you were encountering in your own country. And the conflicted interests of stakeholders. And for example, it's while the licensing boards across the country seem to be willing to work with new ideas, and we saw a lot of this happening during the pandemic when we were able to get temporary licenses for health professionals to work during the pandemic and to support an exhausted health workforce. We sometimes find that professional associations are very interested in ensuring that things do not change. Because when you control supply, you also control demand, and that means you can control pricing of services. So this is a very simplistic view, but it's something to be mindful of. And I think that the last point I want to make right now is that it's racist practices, not race, that becomes a barrier and that becomes an obstacle for people to reach their potential. It's a series of racist practices, like Joel mentioned, closing particular medical schools and not others, that really close the door for generations of individuals to pursue careers in the health professions. And we need to be mindful of that, and we need to speak up about that. So thank you very much.
Thank you so much to our speakers. We're now moving into a Q&A session. Unfortunately, we won't be able to open up questions to our audience, but Viraj and I did prep a few questions. So my question is for any one of our panelists, but are minority populations more or overrepresented in fields like internal medicine or family medicine, and less so in medical specialties like neurology and cardiology? If so, how can we make the healthcare workforce more equitable for physicians pursuing these medical specialties?
I can speak to that a little bit, just based on my personal experience. So one example I'll give is orthopedic surgery is the least diverse specialty out of all the specialties in medicine right now. If you look at the populations, it is similar to what we were talking about with physicians, about 75% white men. And that's the lack of diversity in terms of both gender and race and background in all senses of the word. And many times it's the specialties that earn the most that are the hardest to actually get access to. So orthopedic surgery pays the most, partly because of the fee-for-service reimbursement model that it has, based on like knee replacements and shoulder replacements. So I do think that there is a lot of truth to the fact that there are specific specialties where there's more just lack of diversity, because it kind of becomes a club of who can actually get in and whether you know someone who can give you the skills and the resources to get there. In terms of how to fix it, I think it's things like HEAA is doing right now, giving resources and getting people early on to be able to figure out that this is possible. For me, I actually participated in a program at Howard University Hospital, HBCU. It was my first time getting an opportunity to be with orthopedic surgeons that were Black. And that's very rare, where less than 1% of all orthopedic surgeons are Black. And that inspired me, for them to tell me that I could also become an orthopedic surgeon and get to where they were, even though there were people that didn't look like me or come from the background that I came from. And so I think programs like that really try and break those barriers and exist to bring specifically populations and disrupt the things that we kind of take for granted all the time are what I think are the most effective.
If I could add to that, I don't think we should ever worry that individuals from minoritized community are overrepresented in any health profession, period, ever, not so far. What I lose sleep over is the lack of diversity of the mental health workforce, for example. Because when we talk about clearly an orthopedic surgeon of any color and any background and any gender is important, but if you don't have linguistic and cultural parity in the field of mental health, you essentially don't have services. So that's a piece that I worry about distinctively.
Great. And I have a second question that deviates a little bit from our regularly scheduled programming of questions, but Dr. Fernandez-Pena, when you were speaking about the types of healthcare workers, so community health workers and those who work in clinics and social workers who contribute to the healthcare workforce. Could you just speak a little bit more about the importance of integrating the public health workforce alongside our physicians and our medical specialists?
Gladly. So I was very happy. The congressman earlier is a physician and got a master's in public health. So these are not divorced fields. This is the same field of health. The importance of investing in a public health workforce is equivalent to investing in prevention. So the cost savings therein are enormous. The well-being of the community is much improved. So it's not a luxury, and clearly community health workers are one piece of that, but so are masters in public health individuals, epidemiologists, and medical lab technicians who follow pandemics or who follow the emergence of other kind of communicable diseases. Social workers are oftentimes the glue that keeps a medical team together because they're the ones that understand the context of the individual. I can prescribe something, but if I don't understand that my patient is homeless, then it's going to be very difficult for my patient to follow up with that treatment. Or if they're house insecure, or if they're living in a domestic violence situation, for example. This is typically the field of social workers and other kinds of mental health professionals. When you talk about nutritionists, when you talk about controlling diabetes or obesity, for example, in the Asian or the Latino community, where it's very prevalent, if you don't understand the value of certain food ingredients or the importance, say, of rice or of tortillas in the diet of an individual, how can you deliver a diet that the individual is going to be able to follow? So it's this matter of cultural and linguistic parity that is essential to a well-functioning medical team.
Thank you.
Next question we have is, Dr. Fernandez-Pena, you briefly touched upon this, and Dr. Badalova, you also touched upon this, but in terms of the logistical hurdles, what are the most common hurdles that, international medical graduates face when it comes to their journey, specifically to recertify their licenses, be they financial, social, or political?
Well, I will add maybe a few others to what Jose Ramon mentioned. Just to reiterate, English proficiency is a big barrier, and having programs like Dr. Fernandez-Pena's Welcome Back initiative that helps immigrants with degrees to improve their professional English in the field that they would like to practice again is essential for passing the required exams, as well as, of course, working in the field with other colleagues in hospitals and community clinics and so on and so forth. So for some, it is really what they need is a career advice, because people come at different stages of their careers. So it is quite possible that is not likely that a person with a significant break in their careers because of the war or because of some other reasons, they couldn't practice. So there would be no way that they would go back into the field, even with all the training that they could get. So having someone who could translate what people have, the competencies that they have, into the professions that they could be working, not in the low skilled and jobs out of the field, like working as a cashier in Target. It's really a waste of talent, but working in the medical field, but perhaps not exactly in the field, in the profession that the person was trained for. For instance, one of the pathways for people with strong background in medical and healthcare sciences is to work in research and development. So working in research labs, but someone needs to help this person to figure out where and how to connect with opportunities like that. So again, programs like Welcome Back and others are much needed to help immigrants on this path. One of the barriers that I think is very critical actually lies with employers. And think about employers from their perspective. Potentially there is this pool of workers, right? We don't know where they are, who they are, how to get in touch with them. If they don't come directly from the U.S. schools or kind of a more established pipelines, this population simply drops between the two stools. So people might not even, two chairs, so people might not even be aware of it. But the other issue is that many health providers might not have familiarity with diversity of visa and immigrant statuses. So it's much easier. Employers is being risk averse, is not to even try to hire and give that immigrant, healthcare immigrant professional a chance, than to go through all the hurdles related to immigration. So again, having organizations that could be that knowledgeable and trustworthy broker that would help employers understand that, okay, this person has all the paperwork in order, they are 100% eligible to work. All they need is for you to give them a chance. So working with organizations like that, creating perhaps internships first, or mid-career internships for these individuals is essential, because then employers gain knowledge and familiarity, and they see in practice how this particular worker or set of workers are showing up in the workforce, and it significantly reduces the knowledge barrier that has been a challenge. So I'll start with these three.
And I guess last question for everyone. What are some domestic state or even foreign state sponsored models that we can learn from when it comes to making it easier for international medical graduates to participate in the health workforce?
We experienced a little bit of that again during the pandemic, where in states like Colorado, for example, went out of the way to make it easier for foreign trained health professionals, physicians concretely, to obtain temporary licenses to work under the supervision of a clinician in providing care. Of note, nobody died when that happened. So these individuals that didn't have to be taking the USMLE, that didn't have to spend 6 more years training, were actually capable of providing services. So this is an example we may try to grow and build in other areas. Some countries do exactly this. An individual foreign trained physician, after passing a couple of licensure exams, work under the supervision of a physician for 18 months or a year. And after that, they're granted licensure for a year. And after a good year of not having any issues, they're granted a full licensure. It happens. Again, what are we assessing? How are we assessing these individuals? It's a critically important piece. Other examples, for example, within the Welcome Back Initiative, Jana mentioned the Maryland Welcome Back Center worked closely with 3 health providers and created a nurse in training program where nurses, while they were studying to pass the nursing licensure exam, were working at the hospital under the supervision of nurses. So the hospital got to test drive the model and see that they were good. Once they passed the exam, they were granted jobs in the hospital. So it is possible to do these competency assessments and then pass licensure exams to get people into jobs. Let's not forget that the end is jobs. Also, before I forget, we're talking about individuals who were trained already, who are coming in the United States, or who are already living in the United States. Let's think about the ethical implications of other kind of programs or pipelines that are more dedicated to the brain drain than to the brain gain. So programs like we've been talking about talk about brain waste and incorporating into the as well health workforce. There's no need to get individuals from other countries in when we have this plethora of people here already.
And if I can add a few examples, the good news is that nowadays we have a wide range of examples across states, kind of across topics that could be implemented practically right away. One example is that state of Washington passed a legislation that allows international trained doctors, after they pass certain requirements, to practice on temporary licenses under the U.S. Doctor. So that's a great opportunity, is that you don't have to go through all of the steps. When you're ready and you're eligible, you can participate in a program like that. Another example I'd like to draw from the Canadian example, and really interesting because instead of relying on paper to show what type of credentials you have, they created an alternative credential assessment program. And people, yes, they have to meet certain criteria, but not all 100%. But in that program, people spend 12 weeks of essentially demonstrating the competences that they have to be a doctor. And in the end of the evaluation process, if they pass the exams and evaluation process, they become the fully licensed Canadian doctors. We do not have a system like that, examples like that, but it's great to have that examples like that exist. And as Jose Ramon mentioned, it's important to understand that no one dies as a result of these practices, and that should give confidence to policymakers at the state level, the local levels, and of course at the national levels to promote examples like that. And I'm particularly happy to see that in the Title III of this legislation, there is funding dedicated to organizations like Welcome Back, like Upwardly Global, like many others that would help these organizations to provide services and to address unique barriers that these immigrants face in order to channel them into the workforce, because they are already here. As Jose Ramon mentioned, they are already here. You don't need to go anywhere to look for them. They are already here. All they need is a leg up.
Thank you.
And with that, we have reached our 3 o'clock mark. Thank you so much to our speakers and to our viewers who have watched the panel, and also to the APAICS and the Congressional Tri-Caucuses, CAPAC, CBC, and the Hispanic Caucus, who have led the reintroduction of HEAA for the past 20 years. I want to give a special shout out to Congresswoman Robin Kelly and their team, who have led HEAA through the CBC Brain Trust, the CBC's principal Healthcare Advisory Task Force. And next Congress, the 118th Congress, Congresswoman Barbara Lee's office will be leading this effort to reintroduce the bill. This effort is no easy task. It requires the partnership of several stakeholders and policy players. This year, it was referred to over 13 committees, which just reinforces how extensive and comprehensive this bill is. Again, thank you so much to everyone for joining. And we, as Racial Equity and Social Justice Fellows, thank you for your time today.